Good evening, everyone. I'm Mr. Upra, ISAP Academy founder and director. I would like to talk about medical tourism today because there is a big impact on healthcare both in UK and abroad. So the reason why I'm doing this talk today was there's a lot of patients which came back from overseas and they ended up having multiple surgeries in UK. So I myself did a couple of surgeries for post-op complications following abdominoplasty surgeries abroad. So I would like to talk about medical tourism and what impact on healthcare, as well as what is burden that is causing for NHS. So I would like to talk a bit more about in detail what is the logistics behind medical tourism and how it emerged in the first instance. As you all know, medical tourism is nothing but people who wants to get extra treatment or a different treatment from elsewhere. They travel abroad and get a private treatment elsewhere by paying up for the services. So people traveling abroad for medical treatment is simply called as medical tourism. This could be many reasons. It could be lack of facilities at the local place, or it could be long waiting times, especially after the COVID. There's a long waiting time, so people want to go abroad and get surgeries done. And also, some surgeries have got legal ban in their native countries. For example, in Ireland in the past, abortion was illegal, and also in some countries in Europe, it was illegal. So people travel to UK to get it done. So it's nothing but it's called a circumvention, where a legal system doesn't allow one to perform a type of procedure in one place. So people do go and get it done elsewhere. So a legal ban could be one of the cause for medical tourism, and possibly low cost. So some surgeries are done at very, very low cost in India, Turkey, Pakistan, and sometimes China. So, and Thailand. Thailand is the highest number of recorded procedures in medical tourism. So it could be sometimes attractive packages from the new generation of the hospitals abroad, attracting people for many reasons. Most of the time it is a cosmetic procedures which attracts people, and those who wants to go on holiday want to get a cosmetic procedure done as well. So at this stage I would not I don't want to criticize any of the places or any of the country, any of the hospital. I just want to generally talk about what effects it has on the healthcare system as well as on the individuals. So normally, when you want to go abroad and get a procedure done, you need to have an accredited hospital where you can get a treatment. See, one of the accreditation bodies is JCI, Joint Commission International, which is one of the US accreditation body which accredits international hospitals like that of in India. One of the group of hospitals called Apollo Groups is the first JCI group accredited by US healthcare system, so that the participants can fly from America and get same kind of procedure done in India. So JCI accredits if the hospital meets certain standards. When JCI came first to India, I was one of the doctor who is part of JCI accreditation program, where I was one of the doctor among all the junior doctors. I've also participated and helped in accrediting Apollo Hospital Group. So I was actively participating to maintain high standards pre, post, and during surgery. So there's a quite long checklist for every procedure. So we have to maintain same standards as that of US. So the other one is a QHA Trent accreditation, British scheme. And the third major one is accreditation from Canada. So there's an organization called GCR organization, which accredits lots of clinics across the whole globe. So there are various accreditation bodies. Why I'm talking accreditation bodies is when people, general public, normally doesn't know what is this accreditation is. And so they just get attracted for various packages and then just travel abroad and get it done. And they're not sure whether this hospital is accredited by JCI, QHA, or Canada, or GCR. They're not sure. Or maybe they are not aware. They are completely ignorant that these kind of hospitals where they get a special treatment, abroad paid treatment, need to be accredited by various accrediting bodies so that they'll have the same standards that of the native hospital. So, but a lot of hospitals abroad does not have accreditation. They do portray them as a international hospitals where they can get a medical treatment. That is where pitfall is all about. So that's why I wanted to say that one need to be aware of accreditation of a hospital so that they won't get into a trap. So what are the risks? I'm saying trap. So instead of trap, I'll use the word risks and benefits of getting some treatment, fancy procedure abroad. So you go for a tummy tuck operation, abdominoplasty. So you do get infection sometimes, and so they all advertise like, you stay 2 days in the hospital and go home, and you'll be flying back again. So there's a lot of risk, like you'll be exposed for infections, both endemic, epidemic, and pandemic diseases. So what is meant by endemic? Endemic is like, for example, malaria is quite common in India, and sometimes epidemic diseases. It could be typhoid sometimes, it could be tuberculosis. And pandemic disease, as you all know, COVID could be there. So that's how COVID would have spread to the entire world. So what I'm trying to get is infection rates are quite very high when patients come back from overseas after surgery. So I myself dealt on 4 occasions so far the abdominoplasty wounds getting infected, and on some occasions some of them needed a necrosectomy and washout, further debridements. So I feel very bad for these patients because they were not aware of all these complications prior to their procedure. And when I look at their data, these hospitals where they had this procedure, none of them are accredited by international bodies. So how would one account for all these issues? As a doctor, as a surgeon, you have responsibility to treat the complication when you encounter complication. So what is the rationale? You do surgery and send it to someone else to deal with complications. Is that how it works if these people who are trying to do procedures abroad without having any accreditation? So this is what I want to tell to the general public today that infections risk is quite high with the medical tourism. So the risks are far higher than the benefits. So I myself might have saved 4 patients so far from dying, literally. So this is my first-hand experience. There's no way we can stop people going abroad. We don't have a legal control over people. We can't stop them going to get new treatments abroad. So scientifically also, when you're traveling abroad, long flights, there is a higher risk of DVT and PE, and there's a risk of gangrene if the infection is not treated in time. Sometimes the bugs which grow inside the wounds can cause gangrene of the tissues, necrosis of the tissues, and it could be fatal sometimes. People can die. So patients after a simple procedure will end up having multiple life-saving procedures. So this is why I wanted to make awareness today that medical tourism has got its limitations. So major limitation is risk of infections, DVT, PE, and unnoticed infections can lead to, or untreated infections can lead to necrotizing fasciitis and gangrene of the tissues, and sometimes it is fatal. So my message is, so please check accreditation of the hospital, which hospital is accredited by as per international standards. So it's very important you check accreditation body of the hospital, whether it is accredited, number one, whether it's maintaining standards. It's so important. You're putting your life into risk. So legal issues. Obviously, sometimes you come across malpractice abroad. And what is the litigation? So you can't sue them because sometimes the system from your native country may not allow you to sue them. Or their native country where they are practicing might support them because they might have done procedures under supervision from in their country. So sometimes the practice which is established in the native country may not be applicable to your group practice. So that is why sometimes if there's any malpractice, you may not be able to sue them. Sometimes you may not be able to even ask for explanation. So you are in a situation where when you encounter complication, you end up coming back to us and seek our NHS support and to get through your complications, because it is difficult to go back and spend more money to deal with your complication. So the surgeon who operated initially abroad may not be able to offer you extra help because it costs more for his hospital and he may be busy surgeon there. So you need to be aware of all this situation. I'm not against medical tourism, but when you want to go for a procedure abroad, you need to make sure the hospital where you want to get treated needs to be accredited by various accreditation bodies, and also they should maintain high standards. So can we prosecute people who are not maintaining their standards? It is difficult, even for the legal systems, because it's a cross-border issues. So you can't prosecute a surgeon who has done something majorly wrong. It is impossible sometimes because the legal systems doesn't talk to each other. Can we impose ban on the patients going abroad for non-accredited bodies treatments? Like, for example, if somebody is going abroad where this is altogether a new treatment, never been established very well, never been ethically approved, but still which is under trial or testing. So if patients wants to go abroad, yes, nobody can ban patients going abroad, but can we ban legally? I don't think human rights will allow it to do it. So it's tough to ban people going abroad to get these procedures when they are going for the procedures on their own, voluntarily. You can't stop them going, unfortunately. But we are here facing the problems. When the patients come back with complications, we are dealing with their complications. So it's an unfortunate situation we are in. Yes, definitely there are ethical issues, especially if somebody is trying to go for illegal purchase of organs like transplantation, liver transplantation, stem cell transplantation, and things like that. And also it creates a lot of inequalities. For example, you see there is a two-tier system in India. One is private bodies and the government healthcare, primary and secondary healthcare and tertiary healthcare in the government sector and private sector. There are two different separate standards. Some hospitals are accredited by JCI, some are not. But the more the medical tourism a country attracts, and the inequalities between a government and private sector deepens. And so this is another issue. So the poor people are neglected in some form or the other, as the law is around mostly encouraging medical tourism and trying to establish private practice. So this is creating inequalities, to be honest, but obviously we can't change that. And also sometimes in some countries, if this is the government sector which is offering medical tourism facilities, then there is increasing time for locals who are receiving same services from the same body or same hospital. So, and also sometimes when you see new treatments, people don't understand what is the scientific rationale behind new treatments. People maybe they just want a cure. Unfortunate situation, like some people may just want them to be cured without realizing that there's no cure for some diseases, and they just wanted a new treatment so that there's a hope. But it's a false hope sometimes. People get trapped into and may lose their life. It could be fraud sometimes. So people, there's lots of fraud medical tourism companies which portray themselves as very big companies, and then just take your money, and without any insurance they will treat, and if there is any complication, there's no cost to cover. There's no coverage at all for to deal with complications. So sometimes unproven therapies and therapies which are still in clinical trial, you'll end up having that kind of situation where you're the first person who will be enrolled into that clinical trial. So be aware of malpractice and fraud. So that is why it is important to check the accreditation of a hospital prior to traveling abroad for medical tourism. Sometimes employers sponsor for elective surgeries like TKR, THR, because of long waiting times, and some procedures, even simple things like people travel abroad for gallbladder surgery because they couldn't get into the list within time. So employer sponsored healthcare sometimes is safe for elective surgeries when they outsource Obviously, sometimes employer would have checked whether there is this body is accredited in number one in the first place, so that when you're outsourcing that kind of procedures, then whether it's safe or not, they would have checked. Employer sponsored healthcare is one option. Yes, you can get cross-border health plans and globalization of healthcare. For example, if a company has got um, multiple branches across the globe, their employees can travel abroad and get, if employees sponsoring for their healthcare, yes, they can get different treatments, unless employer has got a tie up with institutes. So just be vigilant about the accreditation again. So if employer is tied up with the various institutions, that is okay. Employer would have checked most, but again, there is no guarantee, because employer would have been trapped also sometimes in outsourcing. So just be vigilant about accreditation. I'm stressing again and again, accreditation is the way you can maintain standards. So why I'm selected this general topic to be made aware for the public, like people, especially health industry, like students and doctors, nurses. So we all know that it is a burden on NHS for us, especially the post-op complications. Patients end up having in intensive care after major infection or gangrene or necrotizing fasciitis. They will end up having an intensive care for a long time. I myself dealt 4 patients so far in last 5 years at least. Those who have traveled to one of the Middle East country, I just don't want to say the name of the country, but it's unfortunate situation. We can't stop because there's no legal ban to travel for medical tourism, but still patients go there and get procedure done and come back here. And yes, it is a burden for our NHS, but I don't know how to stop this. I once in the past discussed with one of the consultant, and he said that he has wrote a letter to health board, for the health ministry, to stop sending patients, stop these people going there. But he says that it's difficult to stop because legally there's no ban. We can't stop them going. That's the bottom line. Obviously, when patients come back and we have increased pressure on A&E, because these patients definitely need beds, and if there's a bed crisis, and if these patients definitely need to redo surgery here, then it is a bed crisis as well as a situation crisis. Sometimes we cannot have 24/7 experienced person who can deal with these kind of unexpected or never seen complications. That is why it is important that we all have to be aware of these problems which we are facing because of medical tourism and people randomly choosing going abroad and getting their procedure done and coming back with the complications and becoming burden on the healthcare locally. And sometimes we also see some patients who came from different countries, not even from UK, who had procedures done elsewhere and come back here because they wanted to survive this complication, and they trust us to deal with these complications. So, but sometimes they may not have right to access NHS services, but as a human being we have right, we can't refuse. Somebody turns up into A&E and asking for treatment. So we do sometimes admit them. Whether they're getting charged separately, we're not sure. But it is, I can see some areas there is a small abuse of the system. You know, people come from various regions and wanted to get their treatments or complications dealt here locally. Although sometimes they can be just a traveler, not necessarily the resident of United Kingdom. So this is why I'm concerned today is like, do we need to put a ban on this medical tourism for at least for procedures where there is no requirement for outsourcing, when we can provide those kind of services here? Our plastic surgeons can do abdominoplasty. Our dental surgeons can implant new dentures. So it's just a waiting game. I don't understand why patients wanted to look very good in a short space of time and ending up having dreadful complications, life-threatening complications. I literally saved a couple of patients who had a necrotizing fasciitis, neglected postoperative care. So it is unfortunate that, you know, we can't stop legally, but we need to make public aware and educate them who wants to go abroad to get cosmetic procedures done, and so that it won't end up having this kind of situation where we are facing burden on NHS. Thank you for listening to my talk. And any questions, please type your queries below. I'll give 5 minutes break before I start heterogeneity testing, which is a part of meta-analysis tutorial today. Welcome back. I got 2 questions from the live chat. So one of the question is there any restriction according to jury that doctors shouldn't prescribe patients procedures that they don't need? Obviously, there is always restriction on the practice. If patient doesn't need a treatment that doesn't benefit the patient, so you can't really prescribe or you can't really do that procedure, like deliberate harm to the patient. So one should not perform procedure and one should not give that kind of treatment where there is no need for if there is no need for that kind of treatment or procedure for that patient. Yes, doctor can be prosecuted and his registration can be cancelled in any country for that matter. So, and there's another question from the viewers. What are the key factors to consider when choosing a destination for medical tourism? It's a tough question to answer, to be honest. So, what are the key factors? So, sometimes some kind of treatments are not available. Number one, I would say some areas, some countries, they don't have liver transplantation. If somebody definitely, if a patient living in that country where there is no service for liver transplantation, like for example Maldives, there's no one who can do liver transplant in Maldives. So if a patient needs liver transplantation, he needs to fly to a country where there is liver transplantation services. Yes, in that situation, yes, it is perfectly acceptable on the medical grounds for medical tourism, provided if the institute which does the transplantation is accredited by international bodies or are maintaining international standards. So the key factor here is to check if that institute which is performing special treatment is accredited, and if that special treatment is ethically approved, and if that institute has performed many procedures in the past without any major complications or with accepted number of complications. international level standards. Destination wise, it is tough to answer because sometimes US people travel to India. Number one reason could be a liver transplant will cost a lot of money in US as opposed to maybe 1/10 in India. So it is perfectly okay from the patient perspective as well as insurance company's perspective for the patient to travel abroad to get a liver transplant in a well recognized institute, well accredited institute by international bodies, and also by a well-known surgeon who practiced for a long time elsewhere in the abroad as well. So we have to check quite a lot of things. Not necessarily, there is no way you can say that this country is better than the other country. It's all down maintaining standards and accreditation. I hope answered your questions, both of your questions. Let's continue with the next topic, which is heterogeneity testing as a part of meta-analysis series. We are going to introduce a concept called heterogeneity testing today. What is heterogeneity? It's nothing but a diversity. It's a clinical diversity. There are so many types of heterogeneity. That's why I would say any kind of variation among studies included in a systematic review or meta-analysis is nothing but heterogeneity. It could be clinical heterogeneity if the participants differ from each other, if the interventions differ from each other, if the outcomes differ from each other in the studies, then it could be clinical heterogeneity. So sometimes it could be methodological heterogeneity. So if studies have got different designs and risk of bias, if you encounter risk of bias in the included studies against those 5 domains which I spoke last week, if there is a risk of bias, or if there is a flaw in the study design, or if the study protocols are not followed accurately, you can get methodological heterogeneity. Obviously, both clinical heterogeneity and methodological heterogeneity can manifest as a statistical heterogeneity, but sometimes not necessarily. If there is a clinical heterogeneity and if there is a methodological heterogeneity, we assume that there is a statistical heterogeneity. Most of the time, if there is a clinical heterogeneity, methodological heterogeneity, you will definitely get statistical heterogeneity. I'm going to show you at the end of this with few forest plots how it works. Most of the time it manifests itself as a consequence of clinical and methodological heterogeneity. How do you identify heterogeneity? If you're doing if you want to do a meta-analysis, you pulled all the data, you got summary stats, and you got confidence intervals, you did lots of variance ratio tests, lots of regression equations, but how do you identify heterogeneity and how do you report it? So there is a system for that. If you do a chi-square test, the Q statistic which you get from chi-square test is a rough estimate of variance basically. And the formula for heterogeneity, as I displayed in this PowerPoint, which is nothing but I square, which is equals to Q. Q is the chi-square statistic, which is derived from chi-square test, minus degrees of freedom divided by Q again into 100, which gives you percentage of heterogeneity. So Q minus degrees of freedom by Q into 100 is the formula for I square. So if the Q is big, if the studies differ from each other, obviously Q will be big. If the Q is big, then the heterogeneity percentage you encounter is also higher. And obviously, if you have lots of studies, then you can subtract some amount of heterogeneity from that, as the formula itself says Q minus degrees of freedom. What is meant by degrees of freedom? So if you have like 8 studies, the degrees of freedom is 8 minus 1, 7 studies. So the more studies you have, more degrees of freedom. The more degrees of freedom you have, less heterogeneity. So it doesn't make sense sometimes. More studies you have, you can even get more heterogeneity, clinical heterogeneity. It's just a formula. So in this formula, the more number of studies you add, technically the heterogeneity should become less, provided if there is no clinical diversity among the included studies. So if you want to include lots of studies, you need to make sure that there is no clinical diversity among the studies. Although you're increasing the degrees of freedom, you can get clinical heterogeneity when you're including a lot of studies. That's why I-squared is multifactorial, not just depends on the number of studies alone. So if you encounter anything up to 40% of heterogeneity, it might not be important, but anything above 50% is substantial. So for just arbitrary purpose, I've given the definitions here. 0 to 40% might not be important. 30 to 60 may represent moderate heterogeneity. 50 to 90 substantial, and above 75 it is definitely considerable heterogeneity. So why is it so important? If somebody doing meta-analysis, if there's a 100% heterogeneity, that does mean that all the studies included in meta-analysis differ from each other. What's the point in pulling all the studies which doesn't talk to each other, which doesn't have same estimates? So as simple as that, the heterogeneity is so important. If higher the heterogeneity, the conclusions you derive will be poor or does not reflect the actual estimates or actual outcomes. How do you address the heterogeneity? So go back and check again if the data is correct. Number one, try not to do a meta-analysis and do different tests like variance ratio test and other things. And if you really just want a publication, you can publish with variance ratio tests results alone. If you are scientifically thinking reasons for heterogeneity, then explore what are the reasons for heterogeneity. Can you ignore the heterogeneity? Obviously, you can ignore the heterogeneity and submit to a journal for publication, but obviously editor will look at it, scientific editor will look at it, and he won't accept you for publication, obviously, because he expects you to have a good result, number one, with low heterogeneity. So you can't really ignore heterogeneity, but there are certain special circumstances where you can ignore heterogeneity. I will touch base on that at a later date. But you cannot really ignore heterogeneity technically. So for time being, if you encounter heterogeneity, try to do a random effects meta-analysis to see what happens, or change the effect measure. What is effect measure? It could be Hedges G statistic or Glasses delta. So change measure to see what happens. And sometimes it is best to exclude the studies which are outliers. That is what we're going to teach in ISAP Academy. So how do you identify outliers? Any study which is not within the 95% confidence intervals, if you take it out and redo forest plot, you may be able to reduce heterogeneity. So excluding some studies which are outliers can reduce heterogeneity, and you're able to publish your results in the form of forest plots. How to exclude studies is again a big art. Basically, you need to learn, construct confidence intervals for pooled summary statistics to see which study is outlier and why it is outlier. What is the risk of bias in that study? Is it a high risk study? Then exclude it. This is how you address heterogeneity. So when you encounter heterogeneity, you need to investigate first what are the reasons for heterogeneity. When you want to investigate reasons for heterogeneity, random effects model, not fixed effect model. So you have to use random effects model to investigate heterogeneity. So heterogeneity can be summed up as tau square, h square, I square. What is tau? Tau square is nothing but it represents the variation among the studies included in a meta-analysis in a random effects model. Square root of tau gives you standard deviation. So if you have studies which are outside to standard deviation, then you better exclude them. If you include the studies which are outside to standard deviation, then you encounter heterogeneity. Tau square will be big number, so which is indirectly a measure of heterogeneity. So tau and standard deviation are interrelated. The more the standard deviation, more the tau square, more the variance, more heterogeneity. As simple as that. So sometimes instead of looking at maths, you can see which variables you can drop down and which variables you can add to reduce the heterogeneity. It's called interaction and effect modification. You did drop some variables, you did change the effect measures, but still there is a heterogeneity. What do you do next? That's when you have to learn how to do subgroup analysis and meta-regression. Meta-regression is another topic. I will definitely take you in depth about meta-regression at a later date. So to touch base, what is subgroup analysis? I'm going to talk about it today. What is subgroups? What are subgroups? So like in patient characteristics, one of the common characteristics is gender, male and female, smoker, non-smoker, diabetic, non-diabetic. So like that. So you can have subgroups based on patient comorbidities, gender, and other things, like those have received intervention, those who have not received intervention. So subgroup is nothing but splitting all the participants into a group which has received a similar kind of intervention, or a group which is common in gender, or a group which has got smokers. So you can take any characteristic and divide them into subgroups, but there should be scientific reason why you want to divide into those subgroups. Sometimes if there's no scientific reason for dividing them into subgroups, you cannot really establish cause and effect relationship. So it is important when you divide them into subgroups, the subgroups should be theoretically linked in one form or the other for the effect measure which you want to measure. Or subgroups should be hypothesized so that when you want to test hypothesis, there is a statistical difference technically. So it's nothing but statistical hypothesis testing. It's not simply saying that Asian, Caucasian, without any relevant to the, or without any scientific reasoning behind interventions. So you cannot say, you can divide the subgroups. You can divide the groups into Asians, Caucasians, or Europeans, or something like that, and you want to see the difference, geographical difference, without any scientific rationale is not appropriate. So when you want to divide subgroups, there must be a scientific reason. For example, elderly patients and children could be subgroups because elderly patients will have a lot of comorbidities. Children may not have comorbidities, so the likelihood of complications, if you're looking at complications post-op, so because elderly population group has got lots of comorbidities, complication rate goes high as opposed to children. So that makes sense when you want to divide into subgroups like elderly population versus children. You want to compare the results of intervention, looking at the complications or cause and effect relationships. That works. So when you want to compare, one question you need to ask, is the effect different in different subgroups? Then yes, you can do subgroup analysis. Okay, so yes, there is effect is different in two different subgroups, but still you need to identify what is the Q value, how big is the Q. If Q is so big that two subgroups differ from each other, then you still cannot do a subgroup analysis, because obviously there is a heterogeneity here, methodological heterogeneity. The bigger the Q value, bigger the heterogeneity you can encounter. So the whole idea of subgroup analysis is to reduce the heterogeneity, so that if you're combining all male patients, we assume that all the male patients' physiological mechanisms, hormonal mechanisms will act in similar way, so that any intervention will have same effect. And you want to compare with the female participants. So in this one subgroup versus another subgroup, how an intervention is having an effect on the outcome measure. So when you want to compare, you want to make sure that the Q value among the included studies should be small. So if Q is not statistic measure here, comparing male versus female here. Q is a statistic measure looking at the male subgroup versus female subgroup between the studies. So Q measures the interstudy variation among two subgroups. If there is a big Q value, if there is a big interstudy variation, obviously there is a clinical heterogeneity. And obviously if the Q is big, it is methodological heterogeneity. So you cannot even proceed with subgroup analysis. So you need to think about a more alternative approach, which is nothing but meta regression. So please stop me. If you have any questions, please ask me. Going further depth into how to deal with heterogeneity. One of the best tactic I was saying is divide them into subgroups and study and select the study characteristics and do subgroup analysis if you encounter a heterogeneity, to reduce the heterogeneity. So for selecting subgroups, you need to have adequate number of studies published in literature, and also you need to specify characteristic in advance, whether this is reported in those articles, and always select small number of characteristics, not like too many characteristics same time. So if you take too many characteristics, again you can encounter clinical heterogeneity. And also every characteristic which you are including for subgroup analysis should have a scientific reasoning. in establishing cause and effect relationship. Sometimes it may not be apparent clinically, so you need to be aware of the effect of a characteristic and be wary of the effect of characteristics, which sometimes may not be apparent, but when you do meta-analysis, you will you'll come across high heterogeneity with high I-square value. And also you need to identify any confounding factors for the characteristics included. What is meant by confounding factors? For example, diabetes and smoking can be confounding factors together in and act as a risk factors for acute limb ischemia. So that is why always identify any confounding factors between the characteristics and among the characteristics. So finally, there are sources of heterogeneity which you may not be able to understand, especially if you're doing a meta-analysis with studies published across the various geographical regions, because there can be a baseline risk. What is meant by baseline risk? It's an aggregate measure of all the case mix factors like age, severity, and also ethnicity. Sometimes they're all linked together, so there is a baseline risk. So the population in Europe might be at higher risk of developing colonic cancer as opposed to Asian population, and Japanese population might be at higher risk of developing upper GI malignancy, gastric cancer. So there is a baseline risk. So that is why it is important. We need to identify baseline risk. That also can contribute to heterogeneity sometimes. And also there is something called control group risk. One can assume that the control group is a pure control so that the intervention does not have any modification or any effect in those groups, but not necessarily. So control group may have inherent baseline risk, and sometimes the baseline risk could be from dose response analysis, and also dose and duration of treatment. That is why it is important you do simple maths like risk ratio, odds ratio, risk difference between the groups before you do meta-analysis with studies published across various geographical regions. You need to identify control group risk and baseline risk when you're adding up studies from various places, various countries. So what I would like to say is effects which has summary statistics that show no relationship with baseline risk should be included in meta-analysis. I'm stressing this point again. The effects which has summary statistics that show no relationship with baseline risk of included population group or study groups should be included in a meta-analysis. So there should not be any relationship with baseline risk or control baseline risk. So what it means, what is effect? Cause and effect. So what is cause? For example, I would give you best example to understand. If you're doing a stapled anastomosis and if you're doing a hand sewn anastomosis and you want to compare the leak rates between hand sewn anastomosis and stapled anastomosis. So the baseline risk is here the elderly person. If you're comparing elderly population with that of younger generation, the baseline risk of lack of blood supply to the colon in the elderly population will alter the outcomes measures or the effects. So that means that if you're comparing two subgroups like elderly population to that of younger generation, looking at the stapled anastomosis versus hand-sewn anastomosis difference in leak rates, then there is obvious baseline risk of age with that of anastomotic leak itself. So there is an inherent baseline risk of age between these two subgroups in doing the meta-analysis. So you cannot simply compare hand-sewn anastomosis with stapled anastomosis among two subgroups where there is an age difference, because there's a baseline risk. I hope you understood my example. With that, I would like to show these three forest plots so that you'll understand what is meant by heterogeneity. So looking at these forest plots, you can see there is a heterogeneity. I-square value is very high. I-square value is above 50%. In both forest plots, you can see how many studies here. Abdullah et al., Parente, Mulder, Hardet, Koss, Tonus, Sastry, 2 times repeated, one in 2006, one in 2008. Hogg et al. So about 1, 2, 3, 4, 5, 6, 7, 8, 9 studies. So 9 studies have got degrees of freedom 8. Q value is about 13 left hand side, and the Q value is 46 on the right hand side, and I-square value is 82%. Obviously there is a heterogeneity, substantial heterogeneity. So this is for 9 studies. So what happens if I take the studies which are published by same author? Let's say Sastry published 2 articles, one in 2006 and one in 2008 with additional data. So which means that the same person has written an article 2 times, and he published data with 2 times with added extra data. So more or less those 2 studies are close to the central pooled estimate or combined pooled estimate, which is a pooled diamond here. So the left graph is showing the sensitivity 0.79, and the left side graph pooled estimate specificity is 0.79. So the Q statistic is 13 for the left graph, Q statistic is 46 for the right graph. That means there is a higher heterogeneity in the right graph, although the degrees of freedom remains same. So when you calculate I-square value, obviously the I-square for your right hand graph will be higher because Q is high and the degrees of freedom remain same. So I'm going to hide the captions because you're not able to see the I-square values. So I'm trying to take the ticker off so that you can see the I-square values displayed on these graphs. See, now we can see. So I'm going to show you previous graph again with I took this. So you can see from the previous slide there are 9 studies included. Sastry has repeated 2 times, one in 2006 and one in 2008, with the Q of 13.43, degrees of freedom 8, and the I-square is 40. So when the combined sensitivity from all these 9 studies on your left hand side graph is 0.79, and the confidence intervals is 0.74 to 0.83. And on your right hand side, combined pooled estimate of specificity from all these 9 studies reported in this first plot is 0.79. The confidence intervals are 0.72 to 0.84. But you can see, although the degrees of freedom remained same, the Q statistic, which is a chi-square test statistic, Q statistic is different when measuring sensitivity and specificity among same included studies. And therefore, I-square, which is the estimate of total amount of heterogeneity is different when you're measuring sensitivity and when you're measuring specificity. I-square value is 40%, roughly around 40.41% in your left-hand side graph, which is pooled sensitivity graph. Whereas when you're doing pooled specificity graph, the I-square value is so high, it is 82.65. What does it mean to the common man or a person who doesn't understand medical statistics? Simply, I can say that you can rely on the sensitivity of the results from these 9 studies, but not specificity, because there is a high heterogeneity when you are combining all these studies while measuring specificity. So if there's a high heterogeneity in measuring specificity, that means that you cannot take that result, combined pooled estimate, to be accurate measure of specificity. There is a lack of accuracy in results. It could be type 1 or it could be type 2 error. So that's why it is important people understand the need for heterogeneity test. This is one of the best graphs which I published in the past, which can show you heterogeneity difference between sensitivity and specificity among the same included studies. So as I said, Sastry has published 2 times study, one in 2006, one in 2008. So let's see, if we take out one of the Sastry paper, what happens? So I took the earlier version of the paper, Sastry et al. 2006, and now I recalculated combined sensitivity and combined specificity. So what happened? So because Sastry 2006 and Sastry 2008 studies are same study, so there's no clinical heterogeneity. That means by removing this non-heterogeneous studies from the pooled analysis, you're creating more heterogeneity. So if you're removing the similar studies, you'll encounter more heterogeneity. So at the moment I removed the previous study published by the same author, the I-square value has jumped up from 40 to 45% while estimating pooled sensitivity of all the 8 studies. So all these 8 studies differ from each other. So therefore, the heterogeneity encounter is also higher compared to previous forest plot, where there were 9 studies with 2 studies resembling with each other. So less heterogeneity. When all the studies differ from each other, then there is a higher heterogeneity. So this is a classic example where if we remove the similar studies, you will encounter higher heterogeneity. So slight increase in I-square value with reduced degrees of freedom from 8 to 7 because I removed one study. So again here, not much change in the specificity I-square value because it's already high. So if I remove all the studies which are outside 95% confidence intervals, this is what I'm trying to teach to all of you. If you remove all the studies from the previous graph, so look at these graphs. So there are some outliers in this study, in this graph. Although there are 8 studies, there are 4 studies which are outliers. So that is a separate talk. I'm going to talk how to detect outliers in a forest plot and which one to exclude. Which are the outliers? Which are outside 95% confidence intervals? Which are the outliers? Which one need to exclude to reduce the heterogeneity? I will do a separate talk on that. But so just for the demonstration purpose, I wanted to reduce the heterogeneity while measuring both sensitivity and specificity. So therefore, I am trying to remove all the studies which are outside 95% confidence intervals. So I identified, by doing a box plot or funnel plot, I identified the outliers and removed those 4 studies. And what happens next? You can see. So the studies which are resembling each other, homogeneous studies, these are the 4 homogeneous studies. You can see suddenly I-square value became 0 while measuring sensitivity, and the I-square value started reducing while measuring specificity as well. Previously it was 85, now it is 74, and for sensitivity the I-square became 0. I'm coining the term nullifying heterogeneity. Whether I'm wrong or right to say this, you can nullify heterogeneity if you remove studies which are outside 95% confidence intervals of the pooled estimates. If you remove all the studies which are outliers outside the box plot, a box plot which has 95% confidence intervals, if you remove all those studies which are outside the box plot, then you can nullify heterogeneity. This is the best example where I removed all other studies. Like in the first graph, there were 9 studies. If I go back, with higher heterogeneity, with the moderate amount of heterogeneity, and finally, when I excluded all those 5 studies outside 95% confidence intervals, you end up having only 4 studies, and therefore almost 0 heterogeneity while measuring combined sensitivity using those 4 studies. You can see the sensitivity, combined sensitivity value has decreased. It is 0.73 here, 0.79 in the previous graph, 0.79 in the previous graph. So when you're removing the outliers, your results are becoming more accurate. That is why heterogeneity testing is very important by constructing funnel plots, forest plots, box plots, and detect outliers and exclude them to see what happens. And after you exclude the studies which are outliers, whatever the combined pooled estimate that comes from the forest plot with low heterogeneity, that is accurate measurement of the pooled estimate of the effect measure. Which means that the combined sensitivity which is represented here is almost 95% accurate. But when you look at the specificity results, there is still heterogeneity 74%, even after removing the outliers. What does it mean technically? Still, combined specificity cannot be 95% accurate when there is a heterogeneity. Although the studies outside the box plots are removed, still when measuring specificity, there is a heterogeneity. So you cannot take that combined pool estimate 0.76 specificity as a true estimate or accurate. So the heterogeneity, in fact, proves whether an estimate, pooled estimate, is accurate or not. I hope you guys understood today the concept of heterogeneity. So in subsequent topics, I'm going to cover about forest plots, funnel plots, box plots, and meta regression. Hope you enjoyed my session today. Please subscribe to ISAP Academy courses, and we'll do live demos in the weekend from 11 a.m. to 1 p.m. for those who have subscribed, and I'm going to take them through the live sessions where I'm going to do statistics with their data. And please visit www.isapacademy and subscribe our meta-analysis courses and meta-regression courses. Thank you. If you have any questions, please type here and I will give 5 minutes time. So I'm waiting for any question and answers. If you don't have any further question, I'd like to end this session today. Thank you very much for joining my live sessions today.